Gastrointestinal stromal tumor, GIST, introduction. Gastrointestinal stromal tumors, GISTs, are the most common mesenchymal tumors of the gastrointestinal GI tract. They arise from the interstitial cells of Cajal, which are pacemaker cells of the gut responsible for motility. GISTs are typically characterized by mutations in the KIT or PDGFRA genes, which drive their development and progression. Epidemiology, incidence, rare, accounting for about 1% of all GI tumors. Age, most commonly diagnosed in people aged 50 to 70 years. Gender, slight male predominance. Sites of occurrence, stomach, 60 to 70%, small intestine, tied 20 to 30%, colon and rectum, 5%, esophagus, rare. Extra GI locations, e.g. omentum, mesentery, very rare. Pathophysiology, 1. Cell of origin. GISTs originate from the interstitial cells of Cajal, located within the muscularis propria of the GI tract. 2. Genetic mutations. KIT gene mutation, 80 to 85%, causes constitutive activation of the tyrosine kinase receptor. PDGFRA mutation, 5 to 10%, alters platelet-derived growth factor receptor alpha. Wild-type GIST, 10-15%. No KIT or PDGFRA mutations, often associated with SDH, succinate dehydrogenase mutations. 3. Growth pattern. GISTs can grow into the lumen or serosal surface, often presenting as exophytic or intramural masses. Clinical features. 1. Symptoms depend on size and location of the tumor. Stomach, epigastric pain, early satiety, GI bleeding. Small intestine, obstruction, intussusception, or bleeding. Colon rectum, altered bowel habits, obstruction. 2. Systemic symptoms, fatigue due to anemia from chronic bleeding. Weight loss in advanced cases. 3 signs, abdominal mass, palpable in large tumors, features of metastasis, e.g. hepatomegaly in liver metastases. Diagnosis. 1. Imaging studies. CT scan, contrast enhanced, best for determining size, location, and spread. MRI, preferred for rectal GISTs and liver metastases. Endoscopic ultrasound, EUS, useful for small gastric GISTs. 2. Endoscopy, may reveal a submucosal mass with central ulceration. 3. Histopathology, spindle cell, epithelioid, or mixed morphology. 4. Immunohistochemistry, positive for CD117, KIT, and NDO1, sensitive markers. May also show positivity for CD34 and smooth muscle actin, SMA. 5. Molecular testing, identifies KIT or PDGFRA mutations to guide therapy. 6. Biopsy, fine needle aspiration or core biopsy, preferred. Staging and risk stratification. 1. Risk stratification, Fletcher's criteria. Factors, tumor size, mitotic rate, and location. High-risk features, tumor 5 centimeters, mitotic rate 550 HPF or extragastric origin. 2. AJCC-TNM staging system, used for formal staging. Treatment. 1. Surgical management, complete surgical resection. Primary treatment for localized GISTs. Aim, negative margins, R0 resection, avoiding tumor rupture. Lymphadenectomy is not routinely performed, as GISTs rarely metastasize to lymph nodes. Minimally invasive surgery for small gastric or duodenal GISTs. 2. Adjuvant therapy, imatinib, tyrosine kinase inhibitor, indicated for high-risk cases post-surgery. Dosage, 400 milligrams per day. 3. Advanced metastatic disease, targeted therapy, first line, imatinib. Second line, sunitinib if resistant to imatinib. Third line, regorafenib. Surgery may be considered in select cases for symptomatic relief. 4. Neoadjuvant therapy, used to downstage large tumors before surgery. 5. Palliative care, for unresectable or metastatic disease resistant to therapy. Prognosis, localized disease, excellent prognosis with complete surgical resection. 5-year survival, 60 to 90%. Advanced disease. 5-year survival depends on response to tyrosine kinase inhibitors. 1. Imaging, regular CT scans, every 3 to 6 months for the first 3 years, then annually. 2. Surveillance, to detect recurrences or metastasis, common in the liver or peritoneum. Future directions. 1. Development of newer tyrosine kinase inhibitors. 2. Identification of additional genetic targets. 3. Research into immunotherapy and combination treatments. Conclusion. GIST is a rare but significant GI tumor requiring multidisciplinary management. Advances in molecular biology have revolutionized its treatment, with targeted therapies such as tyrosine kinase inhibitors dramatically improving outcomes in high-risk and metastatic cases.